And Taryn Prestige is sitting over there. Wave, Taryn. She actually did the PowerPoint presentation for the delirium tremens part. So she is interesting thing if you ever wanted to know. There's 4 types of advanced practice nurses. There are clinical nurse specialists, which is me. There are nurse practitioners, which is what most people know as advanced practice nurses. Then there's certified nurse anesthetists, all down there in an OR, barely ever come out. And then there's the midwives. So you either birth babies, you knock people out, or you write prescriptions. And then it's like, well, what does the CNS do? Everything that the other ones won't do, because we never wanted to not be a nurse. We always wanted to stay in nursing. So that's kind of the easiest way to what is a CNS? Well, I chase nurses and patients instead of chasing around doctors. That's the biggest difference between a CNS and a nurse practitioner. There's other things, we're in the backward state of Georgia, so there's a lot of other differences between CNSs and other advanced practice nurses in Georgia, but that's only because we're in Georgia. You go outside of this state and it's all the same. So Taryn has finished her nurse practitioner part of her degree at Georgia State University, and now she's got to do over 500 clinical hours following a clinical nurse specialist to find out what we do. And so she actually, as one of her projects, did the delirium tremens portion of this presentation that we're going to do today. So I'm not laying blame, I'm actually laying accolades on what a great job she did. So when you're evaluating me, you're also evaluating her, and she actually kind of needs that for her project. So, you know, where there's like the comment sections and stuff, please go ahead and utilize that so that we can use it for her paperwork and such. One of the best parts about being a CNS is you get to mentor nursing, and it's everyone from, you know, housekeeping on up. But in my mind, I am the C = RN student. Never wanted the A, always wanted the student who wasn't getting an A, because usually that was your better person when you had your patients, you know, because they could think like a normal human being instead of think like a book. So every time I'm doing an educational module, I always think of adult learning principles, and one of those is what type of ways do people learn. And you know, some people can read a book and completely absorb it, and usually they go to medical school, and then other people are more hands-on learners, and that's where your adult learning principles come in, and those of us like to really get our hands dirty on stuff. So that's why we've utilized the simulation mannequins for doing the pressure ulcer and the CAUTI checkoffs. So that's something I kind of brought to Noonan, is saying, let's get our hands dirty, because that's how we use the tools and that's how we learn the stuff that we're doing. When you can't have a mannequin present and I can't make the mannequin, you know, go into delirium, then I utilize things like videos. And a lot of times they'll speak 1,000 words. So when Carol was, you know, saying another one, that's, I said, oh, I have got to show you this video. So this will get you laughing, which gets your heart rate up, which gets oxygen to your brain, and then you'll be all alert for my presentation. So, yeah, anybody seen The Hangover? Remember the guy in The Hangover? This is him. Well, eventually.
Game of charade based on film titles turning into a sudden cardiac event? Bam! Shiklaki! No? What? Think you're better than me? Well, it happens, all right? It's a real-life situation! Now my daughter's here, call 911, push hard and fast, okay? Focus! And yes, the beat of staying alive really works.
Do y'all know in real life he's an OBGYN?
No.
Mm-hmm. He went into acting when he got, you know, sick and tired of
Disco
OBGYN.
to save lives. Yes, disco, huh? Check it out. What do you think? What? It's Fontaine!
started saying, they were going, CPR, CPR, chest compressions, chest compressions. So you could do either song to make you remember how to get your 100 beats per minute. But I just loved that. And we played that. Third part of the HRSA Comprehensive Geriatric Education Grant brings me to some long-term care facilities and some skilled nursing facilities. And one of them is Signature of Buckhead. So I had to do a cardiac assessment class because they're going to start taking pulmonary hypertension patients and trach patients and late stage CHFers and things they really hadn't taken at this skilled nursing facility before. So I, was going over where to assess for heart sounds and, ejection fractions and, really what's going on with everything. And then I said, we really have to do CPR. So at a certain point in time, I said, you gotta shut up when you lecture to just make sure that people are getting what you're talking about, and if you just talk and talk and talk and talk, then anybody's going to tone you out, no matter how enthusiastic of a presenter you are. So I put this in here, and even Night Shift woke up and started laughing hysterically. So that's when you know you got a good video, is when Night Shift starts laughing. So, but yeah, that was right off of YouTube. And just as an FYI, when you search Ken Jeong on YouTube, it will show you some of the outtakes of some of the videos. You probably don't want kids nearby because he takes things way past the notch of normality in some of the outtakes, not only from The Bachelor, The Hangover, but from the movie that he was in, where she gets pregnant. Anybody remember that movie? Knocked Up, yes, Knocked Up, exactly. So the outtakes are hilarious, but just FYI, I was playing those, and my 2-year-old, then started using the S word, so, gotta be aware of that. All right, so we're gonna switch gears a little bit and go into delirium tremens, and the CY protocol. Originally, this speech was going to be done by, I think, one of the neurologists, and they were going to go over the DTs, and they were going to go over the CY protocols, but it smoothly goes right into the reason that I can do this through the HRSA grant, is delirium is a seamless transition to delirium tremens. Obvious reasons because of the titles there. So, this should do it, right? Nope, that ain't it. Here, you probably, there we go, page up, page down. No?
I always have to just go to the screen.
There we go, okay. So delirium is a lot more common than we think. When they actually, did you know delirium doesn't have a DRG? It doesn't really have a diagnostic related group. So when they're actually saying somebody's in delirium, we really can't get paid for it. And the problem is it's really, really expensive. So when you're trying to really measure how much delirium is occurring, when a physician can say that a patient is in delirium, like in their notes, we can extract that and see that we got about 20% hospitalized older adults. And usually that's anybody from like 65 and up. But that's only people who wrote it. Then we have a guesstimation based on data extraction of symptoms and what's kind of happening with their patients. And they're thinking it's more like 50% of hospitalized older adults. Then you see more data when they're getting into ICUs. They think it's up to 80%. And we'll go into some of the different presentations of it, and you'll be like, oh my God, yeah, 3 out of 4 of my patients, in the last week have had that. It does have a poor prognosis, and unfortunately, if you don't treat it, they die. So that to me is a pretty significant medical emergency. They do also have a longer hospital admission, so we can't get them out. And remember, the whole purpose of DRGs is that you get paid for a certain amount of time that we think we can cure a patient. So if you got somebody who has a DRG of, like, let's say 3 days for an acute exacerbation of CHF, and we keep them 4 days, we really kind of only got paid for 3 days. But if we get them out in 2 days, we're doing the happy dance because then we still got paid for 3 days. So that's why we're always trying to get people out in less time than the normal DRGs. So with these patients with delirium, sometimes their hospital stays are actually twice what the actual DRG diagnosis is. There's an increased risk of later dementia, and that should make sense. Anything going wrong a little bit with the brain, over time is going to go wrong a lot with the brain later on. All right, so what does delirium feel like? When I was playing on YouTube, I found this video, which I thought was actually really, really good. I'm not going to see Ken right now. I'm going to see this one.
Example, the flow of acetylcholine, the neurotransmitter most commonly associated with delirium, is reduced and depleted. However, noradrenergic system activity is increased in most deliria associated with drug withdrawal. This disturbance in brain activity results in confusion, inattention, and other symptoms of deliria.
So it's really
I was in the hospital, be it what I was there for, it doesn't really matter. But I know I was not quite myself. I wasn't Betty McTaggart at all. I wasn't Elizabeth McTaggart, but I was me, and I was there. And this day, we discovered, the hospital people, that we were going to be in this one big room. And all of a sudden, the room started to change. It would get smaller. If you've been in a castle, and you know that beautiful brown wood all started to close up. You would get one room closing into another, and the people would all walk out and they go somewhere else. Until it got to the part where here am I over by the door, and it was gradually closing.
A delirium can leave a person with long-term psychological distress, which can manifest as post-traumatic stress disorder.
So what was the other thing that we talked about earlier in today's symposium that can also cause post-traumatic stress disorder? Oh, come on, he was a great presenter. Paralytics. When you got somebody on a vent and you actually are paralyzing them and they're conscious of that, that can cause some severe psychological distress, and patients can actually have post-traumatic stress disorder from the paralytics. So the psychological repercussions of some of our necessary things that we do in ICU are much more longer lasting. And let's be honest, we're here in the South, and with our older adults, any kind of psychiatric diagnosis is still seen as a stigma. So they typically don't seek psychiatric counseling or help, and rarely do they actually follow through with the treatment of it. And of course, that can have even more sequelae that can extend from that. So just be aware that, that's a pretty darn frightening thing that's occurring for these people. Oops. And so we actually know what delirium is. We got chemical imbalances in the brain. And whenever you've got all these chemical neurotransmitters that are kind of going haywire in the brain, you always have to think about, well, the brain is the one that's supposed to tell everybody else what to do. So then all your neurohormonal communication of the rest of the body is going to be impaired as well. So then that can link you back into these medical emergencies. So if the brain's not telling, like let's say the kidneys, whether or not to diurese or whether or not to hold on to water and recycle it, well then you can have kidney types of issues. Or if it's not telling the heart to beat faster when it needs to maybe increase the heart rate to get more circulation to a part of the body, then you've got issues there. So again, it starts with the brain, but it can actually affect much more of the body systems than we think. So then we go into this one.
A hospital environment designed to be elder-friendly will reduce and prevent delirium. Some simple changes include large, easy-to-read room numbers and other strategies to help patients find their way around with less confusion.
Assuming they're
Bathroom mirrors low enough to be seen from a wheelchair encourage self-care and independence. Newspapers, calendars, and clocks help with orientation and engagement in daily life.
Hi, Gord. It's Donna.
I'm your nurse today. Do you remember me?
I've been looking after you all morning. The most important thing a nurse needs to do when she's calming a delusional patient is to be reassuring and calming. How are you feeling? Not so good? Take a minute. Wake up. To provide a restful environment with a minimal of distractions.
It's lunchtime. We're going to have something to eat.
The person might need to be fed because for the time being they've forgotten how to do that.
We're going to sit you up on the side of the bed.
And most of all, don't argue with their delusions. If they think there's a snake on the foot of the bed, all they really need to know is that you're going to keep them safe and take care of them. One of the things that we often find with our older adults, if they do become delirious, is they'll pull out their tubes. So we do not use Foley catheters. We avoid them. If a patient cannot void, we will do in and out caps. We try to get them up to a commode at the minimum and get them to void. They empty their bladder. We don't have as many urinary tract infections because the bladder is totally empty. There's not that little residual that's left there. Also, that getting up and down really helps to ambulate the patient, get circulation going, get oxygen to the brain, and keep them orientated. It's also a normal function, so we try to create normal functions. With our intravenous, we often will have an infuser plug put in, so if they do remove it, often it's not the site that we have lost, but just simply the tubing. We also try to get them hydrated quite quickly so we can get rid of that IV.
Now, why don't you take a sip of apple juice while I start to open your containers for you?
Okay, so a little bit distracting to have somebody talking to you and their face is morphing and their voice is changing, and then you see something out of the corner of your eye and realize the bugs are crawling through the... And what's the most common thing we hear people say? What kind of bugs? Spiders, right. So that's why they showed that on the video. And a lot of times there's not really spiders or bugs, but it is always good to check, because if you've ever spilled TPN, it's almost impossible to get that stuff actually out of the nooks and crevices, and it can be very, very difficult to actually get rid of the bug problems from spilled TPN. But going back to the bug issues, you don't say there's no bugs on the wall. The best option to do is to say, is it right here? Did I get it? And kind of, it's not that you're feeding into the delirium. It's that you're going where they are at that moment in time. So if you can get rid of whatever they think is there, then that's one method of reassurance. The other thing that you can tell them is, we will have an exterminator come in and we'll take care of the bugs, you're safe, and the hospital is going to take good care of you. So you can say the hospital, that is a method of orientation. You can also point to the clocks, or you can point to the calendars. And the way that the ICU is set up at this hospital is kind of interesting, because with the two doors, you know how the largest door and where the patient is actually looking at faces out to the nurse's station. So they're seeing monitors and they're seeing people walking by, and there's a lot of activity out there, and they're seeing all these other doors. So how many people have had a patient say that they're like in a train station or an airport? Anybody getting some? I'm seeing some nods. Yeah, because there's so much activity out there, and their brain is seeing all these impulses coming in, but because of the delirium, they're not able to process it correctly. And then, of course, they will think that they need to catch that train. So then they may need to get up, and they need to get to that train or what have you. What we've done in some situations is, a gentleman said that his wife was coming to get him, and then was the car pulled up yet? So everybody who walked past this gentleman's room would say, she's not downstairs yet, but we'll let you know when she is. But stay in your room, because when she gets here, if you leave, we can't find you. So every single person, I mean, respiratory therapy, wound care, the nursing staff, the CNAs, the physicians, everybody was on board, that every time they walked past this person's room, they would say, we're still waiting, we're still looking for her, just stay here, she should be here soon. That lasted 4 days. And then we corrected the underlying electrolyte imbalance that was causing this person's delirium. Didn't even remember it, you know? So again, delirium was one of those situations that once you correct the underlying imbalance, usually those symptoms will resolve, but it sort of depends on the patient. We've had people who correct, like one of them, I said electrolyte imbalance, and I'm thinking of a particular patient, and within hours, they were completely clear. Then you have other people who maybe their physiologic reserves aren't as good, and it takes them maybe days to weeks for them to actually clear up. So it really depends on the patient. And I know that is a really tough answer to give, but unfortunately that's the situation with delirium. Okay, so moving on. Here are the causes and here are the treatments. Now luckily you've actually seen this before. It was actually in a poster that looked a lot like this, because people commonly get delirium and dementia confused. And I always think of the tortoise and the hare. Dementia is like the tortoise. It's slow. It's not going to come on all of a sudden. It's insidious, meaning it's progressive, and it will take years for the dementia to truly get to its worst and final stages. Now delirium is the hare. Really fast, quick onset. This is a sudden change for this patient that is not their normal. So one thing that people get confused is sundowners. Well, if you have a sundowning patient who has sundown for the last 6 months, is that a new sudden onset change, or is that pretty continuous for this patient? Pretty continuous, so that's where you get your dementia. But if they've never sundown before, and all of a sudden they're pulling everything out, trying to climb over the bed rails, is that a sudden onset? Yes, so that would be your delirium. So it's your abrupt versus your insidious. The attention is a key aspect to this, meaning it's impaired. They can't focus on something for a long period of time. What about a dementia patient? Do they not tell you the same story over, and over again? They have to have a certain amount of attention to tell you that whole story. A delirium patient wouldn't be able to get through that. They're like ADH to the squared power. You know, they are just off in 2,000 different directions at once. The consciousness is fluctuating or reduced with delirium, and it's clear with dementia. So you're not going to see level of consciousness goes from like obtunded to alert to, lethargic or whatever. You're pretty much clear on the dementia. And then the speech can be incoherent or disorganized, but we're going to go into the CAM ICU because you're going to have patients who may not be verbal. They may actually be, on sedatives or paralytics or what have you. So you need like alternative ways to get around that. And then this whole thing down here was all of the causes of delirium, and on the bottom was all of your nursing or medical interventions that you do to take care of it. So let me back up one, because I blew that up and made it bigger. So the causes of delirium, the anachronism is delirium. D for dementia, E for electrolyte imbalance, L for lungs or respiratory, I for infection or inflammation, R for RX, meaning medications and polypharmacy, I for immobility or injury, U for unfamiliar environment, and M for metabolic disorders. So corresponding with what you actually do to treat it. So the first thing for dementia, well, you've already got some sort of an organic underlying brain disorder with the dementia. So that can actually affect whether or not those neurotransmitters are actually communicating properly. So you want to know whether or not they truly are delirium, or if you're kind of seeing a dementia patient who's never been diagnosed before. Because remember what I said about, we're in the South, psychological illnesses are a stigma. A lot of times we have seen family members who want the diagnosis of dementia removed from the permanent medical record on a patient. Because they say, no, we don't want that in there, mama's just forgetful, or what have you. Whereas she's actually been seen by a psychiatrist and had the proper diagnostic tests done to say, yes, they're in whatever stage of Alzheimer's or whatever type of dementia that they may have. So the CAM actually is called a confusion assessment method, and we're going to go over how to do that. And that's the way you determine whether or not it's delirium. And then for the dementia, you can use a mini cog. And y'all seen some of the posters that have been put up over the last year and a half about the clock draws. Well, first off, you got to have enough attention to draw a clock, right? And somebody who's in delirium is not going to be able to hold their attention to draw a dang clock. So if they're in delirium, forget the clock draw. You're not even going near that. But if they're with dementia, typically the clock draw says it all. And you want to have them draw that on the back, let's be honest. The alcohol swabs are a little bit too little, but I know that's the nurse's favorite post-it note is an alcohol swab. But paper towels, you just take off a paper towel, set it in front of a patient, and then have them actually draw a clock. I like to hang on to those in the room because you want everybody coming in there seeing that clock draw. Because if the family members have watched mom or daddy do that clock draw and have a real hard time putting any numbers, and then they can't put the hands at 10 minutes after 11, they pretty much get it. They realize mom is not going to be able to balance the checkbook and pay the bills, and we don't know where the car is going to end up when she's driving to the post office. My grandmother, the car went through the post office, and luckily no one was hurt. But you really want to hang on to those clocks. So, and you want to know if the patient has been diagnosed previously with that dementia, because if they have, done deal. Don't even worry about the clock drops. You already got a diagnosis. So then we move on to electrolyte imbalance. Well, you want to correct the underlying disorder. So of course you're looking at your sodium, potassiums, calciums, chlorides, phosphorus, all that kind of good stuff. You want to restore your fluid volume. And remember, with your older adult patients, they start off with less volume than younger adults. So when you talk about the glass half empty or half full, they're starting off half empty. So when it comes to something like an anticholinergic that can dehydrate them, they're going to go down faster into dehydration than a normal, like middle-aged adult would. Okay, so they have less room to move, so to speak. So dehydration is a real issue for them. Now, of course, you can look at your labs, but you also want to look at your eyes and nose. And you're truly looking at whether or not somebody's positive or negative. And that correlates with the lab. You can't just go on somebody's BUN and creatinine because you got older kidneys. Are they going to work just as fast as a 45-year-old's kidney? No. So is their BUN and creatinine really going to be that great of a measure of their hydration status? No. If they were 45, yes, but not at like 75. And then, of course, integumentary assessment. How many old people have fantastic skin that bounces right back on the back of their hand? None, unless they had a hand lift or something instead of a facelift. So honestly, you're supposed to be doing skin turgor over the clavicle on your older adults. That will snap back, not on the back of the hand, okay? Then lungs, respiratory. You really do want to be doing your incentive spirometer every 2 hours while they're awake. Don't wake them up every night because that'll put them in delirium. And assess their lungs. Are they junky? Are they clear? Are they moving the air? You know, it's always about getting those stethoscopes on people because you want the clinical presentation of a patient in your mind to match whatever your laboratory and your diagnostic tests say. Okay? Of course, your SpO2s, and then you get them up in the chair. And I always think about getting people up in the chair is really just looking at volumes and fluids. So if you have this water bottle, well, you got the air up at the top. Well, then if I pour it sideways, see how the air comes towards the head of the bottle? Well, when somebody's laying in a bed constantly, they don't have as much air to necessarily breathe because of gravity sort of like equalizing all of the fluid status in your lungs. Then you think about, and you've seen these patients, right? They're like your COPDers and different people who they got to sit upright. Or how about your CHFers with a lot of fluid in the lungs? What do they tell you? Well, it was 1 pillow, then it was 2 pillows, then it was 3 pillows, and now I sleep in the recliner, right? And it's all about where their fluid status is in their lungs. Thank you. I promise I didn't spit on it. Then you also get them moving, because whenever you're moving, you're actually getting the circulation flowing to all parts of the body. So ambulating, early ambulation for ICU patients is absolutely integral, because what we know is that it affects all of the different body systems when you're ambulating your ICU patients. And of course, you can't just like, oh, say, let's take them then with us. Obviously, you got to do progressive ambulation. But for a lot of our patients, like at Bigmont, we see them in the post-open heart surgery. Sometimes we'll start their progressive ambulation within 12 hours after their open heart surgery. So it bypasses their valves. So we're moving good. And we're having better outcomes with these people. Don't forget about the age-old term, cough and deep breathe. So even if you don't have an IS or somebody's not cognitively intact to use an IS, have them do the coughing and the deep breathing. Then we move on to infection and inflammation. Well, if you got an infection or inflammation, you need more calories to fight it. So you've got to watch your nutrition for these patients. And go ahead and get a dietitian consult if you can. But identify the source of infection, because that's where you're going to target that source, cure it, and then you're going to see your delirium clear up. Avoid indwelling Foley catheters. I say it's just another tube to pull. Don't give them anything else to yank on. But the other thing about it is that most of our delirium patients do have a higher susceptibility to UTIs. They're still trying to figure out what that is, whether or not it's just a lowered immunity, or whether or not it's because they're fiddling with things, or whether or not it's because they have longer ICU stays. They're still not entirely sure why. But we do know they have a way higher rate of catheter-associated UTIs and any invasive lines. I used to beg people to, start IVs, up in the, like right here is a pretty decent vein. See, I'm so white, you can see everything on me. But once you start an IV, or you put a central line on somebody in here, and then you put the gown over it, out of sight, out of mind, right? And that's usually a good solution. Not always, but sometimes. All right, then we go into polypharmacy. Well, the more drugs, the more possible side effects and drug interactions. So really you want to try and avoid that at all costs, which is really tough in the ICU because there's so many physicians on board that everybody's got their treatment. And the whole reason they're prescribing different medications is so they get reimbursement. Remember, if they don't prescribe a drug or they use a diagnostic test for something, there's actually less income. And then when they go to court, the patients will say, well, why do you think mom has pneumonia? Well, because their lungs sounded exactly like pneumonia. Well, why didn't you do an x-ray? So a lot of times our culture also reinforces doing a lot of unnecessary things when all we had to have was really good assessment skills. always feel so bad for physicians. That's why I love nursing, is because we don't have to go there. But they're constantly having to back up what they know from their assessment is the issue with their patients. So in nursing, you know how we say, I have a bad feeling about a patient, and a physician will do what we want them to do? We really need to harp on that as nurses and go with our guts, because we have fantastic intuition. And our assessment skills are spot on. And the physicians are wanting our assessments to tell them, where's this delirium coming from? So moving on from that, I already told you about anticholinergics. With immobility and injury, we already talked about moving them, getting them walking. You see all the prevention of pain, pressure ulcers, impactions. None of us want to do that. Then unfamiliar environment. Have the patient actually use their aids. Put on the glasses, put in the hearing aids, and put in the dentures. A lot of patients will associate no teeth with I'm asleep. When they have their teeth in, they say, okay, daytime, gotta wake up, just need to be doing things. So that's sort of one of the things that they do first thing in the morning. So that really helps out. Obviously hearing aids, because you want them to hear your instructions with what you're trying to tell them, and visualizing that nurse's station, being able to tell that's not a train station. I thought it was, but that's not a train station. I got my glasses on now. Ask the family members to remain present if at all possible. Do y'all have open visiting hours in our ICU here?
No.
Okay, that's probably going to change. It's becoming a nationwide change. It's been resisted, but pretty much the powers that be, you know how the government is quite involved in what we do in healthcare, are pretty much mandating that a lot of ICUs are pretty much open visiting hours. So just kind of be aware that's coming down the pipes. And some of our other hospitals in the Piedmont system have changed that already. Metabolic disorders, well, really you can use the bladder scanners or just palpate the bladders to see whether or not somebody's distended. And that can, I know it's subtle, but that can actually throw somebody into delirium. If no BM in 5 days, watch for the impaction. Remember, impaction can also cause incontinence. Makes sense, right? Full colon, pushing on the bladder, everything leaks out. Okay, so we already did this one. We're skipping on to detecting it. Okay, Taryn, you mind passing those out? The CAM is called the Confusion Assessment Method, and what it is measuring is inattention, fluctuation, disorganized thinking, and the altered level of consciousness. However, one of the biggest things that we miss is hypoactive delirium. I call this the perfect patient. A hypoactive delirium patient lays in the bed, doesn't pull on anything, doesn't say much to you, doesn't really even look like they're registering what's going on. You just think they, I don't know, somebody gave them too much Versed at their last, diagnostic test. The hypoactive deliriums tend to be the #1 missed diagnoses in our intensive care units across the nation. So keep that in mind. The #1 is this acute onset or fluctuating course? If it's not, stop. Don't even ask the rest of the questions. This is my favorite nursing screening tool because it's the quickest one on the face of this earth. Either this is new or it's not. If it's not a new thing, you have just completed the CAM screening tool. Pretty good, huh? Okay, let's say it is something new. Mom has never acted like this before. What did y'all do to her? Right? Can the patient count backwards from 20 to 1? 20, 19, 18, 17. Oh, what's this pen over here? Did I make it? No, I got distracted. I had inattention, right? Even if I came back to it and started over, 20, 19, 18, 17, 14, 13, 9. Did I make it?
No.
No, because I wasn't getting my numbers right, correct? So either they don't make it all the way to 1 or they mess up their numbers, they failed that part. Then can the patient answer the following questions correctly? There's actually 2 sets of these questions, so that if ICU asked one of them and she got bumped up to the floor and something's a little off, the floor has a whole set of different questions that they can ask as well. And is it going to rain inside? All right, so does a stone float on water? Are there fish in the sea? And y'all can read through those. Now, they don't have to get them all wrong. If they get one of these wrong, they failed that question. And then the last one is, do you assess an altered level of consciousness? Remember, they can be hyperactive, pulling out tubes, pulling out lines, climbing over the bed rails, or they can be obviously comatose. You know what that is. Okay. So then you got the hyper alerts. Y'all are really good on identifying those patients because they're yanking everything out. They're just like it's that patient, right? But watch the hypoactive. Those are the ones who are just sitting there and not really talking to you. So what do you do when you got a nonverbal intubated patient? Well, you perform something that's called the CAM ICU. And since your patient can't talk back to you, it kind of depends on whether or not they can actually nod their heads yes or no, or whether or not they can squeeze your hands. So here is how to do the CAM ICU.
Hello, my name is Lee Cutler. I'm a consultant nurse in critical care. I'm going to show you how to use the CAM ICU, it's a confusion assessment method for detecting delirium in critically ill patients. I've had a handover on duty this morning, and the nurse tells me that she suspects there may be some acute changes in her mental status. So I'm going to run through the practical parts of the test to see how clearly she's thinking this morning. Hello Julie, how are you? My name's Lee, I'm one of the nurses. I want to see how clearly you're thinking this morning, so I want to ask you some simple questions. Is that okay? First of all, can you hold my hand? Now I want you to squeeze my hand when I say the letter A, only the letter A. Do you understand? Give my hand a squeeze at first. That's great, that's a good strong squeeze. Okay, so we'll start the letters now. H, A, B, E, A, H, A, R, T. That's fine. Got all those correct. I want to ask you some simple logic questions now. Is that okay? 4 questions. Would you use a saw to cut wood? Are there fish in the sea? Is 1 pound heavier than 2 pounds? And would a stone float in water? Okay, that's great. Last part of the test now. Can you use this hand to hold 2 fingers up like this? And can you do the same with this hand? That's great. Thank you. That's the end of the test. You're thinking nice and clearly. Anything you want to ask me? Okay. And that's the end of the test. She's delirium negative. We'll stop the test there.
So obviously any patient who's sedated or not can open their eyes and say their name and can keep their eyes open for the duration of the test. They can't be dozing in and out, because remember when they doze off and they come back, they're starting all over again. So here's exactly what we went over on our slides. And you have to have 1 and 2 and 3 or 4. So 3 and 4 kind of interchangeable. So basically you're assessing whether or not they're themselves. Is there any kind of reduced or fluctuating Glasgow Coma Scale, and they use also something called ABPU. Sedation scores, but not related to the medications. We talked about agitated hyperalert, and here it is. Have a heart. Heart is spelled H-A-A-R-T, and those are the letters that you're going to use for the patient to squeeze your hand. Okay, you can also say save a heart. Either way, have a heart or save a heart.
I want to see how clearly you're thinking this morning.
So all he's going to do is go over it again.
Okay.
So I'm actually going to back out of that.
First of all, can you hold my hand?
See something real quick. All right. So delirium is present. Oops. Hold on. When there we go. Acute onset and inattention. So you have to have the 1 and the 2. And you have either 3, disorganized thinking, that's the stone float in water and different things like that, or the altered level of consciousness. So let's say they can't like really answer your questions about stones floating in water, they're just kind of staring at you and not really getting it. Then look at their level of consciousness. Obviously if they're constantly dozing in and out, there you got it. Make sense? And I believe, oh sorry. Yep, that's it for that one. All right, so any questions on the CAM ICU? Okay, now obviously for nonverbal intubated patients, they still have to be able to be alert. So if you're doing like a sedation vacation for a patient, that might be an option to actually do the CAM ICU on them. Now if they're CAM positive, which means they're in delirium, which is a medical emergency, Are you going to care about whether or not they have dementia? No. Correct. You're going to want to take care of the medical emergency, which is the delirium. Don't worry about clock draws and all this other kind of mess. Take care of what's causing that delirium because it can lead to death if it's untreated. Okay? Alrighty, so moving on, we're going to go into preventing, and they went over this a little bit in the video, so I'm not going to read all through them, but realize that the noise and the disturbance reduction at night, that's a little bit difficult with the geographic setup of the ICU in this location, but some things that you can do is, dim the lights and, the doors that are able to be closed and using the blinds and that sort of thing. So you do have some options there. The biggest one is early mobilization, but you really have to have physical therapy and respiratory therapy completely on board for the early mobilization, because obviously they need to be stable, and then you also need somebody who's not going to fall the first time you go to get them out of bed. So typically you want PT to see them and to be able to at least assess what's their muscle strain. Because remember, when you got a paralytic on board, that's pretty much going to affect other muscle systems whether or not you realize it or not, okay? So can't be getting anybody up and sitting and all that kind of stuff when they're paralytic. We talked about all of the glasses, hearing aids, that sort of a thing, the fluid imbalances. And again, don't rely on the labs. Trust your intuition. When you're assessing something that doesn't quite match up, I don't care if the labs are normal. If what you're assessing doesn't function as normal or within normal limits, you need to go ahead and call somebody and maybe even get a second opinion in there on, hey, do you hear this too? Oh God, yeah, I heard the S3 too. Well, labs look okay. Still, something's going on. All right, so how do we manage them? Well, we control the environment. We talked about going where the patient is, the guy with the taxi cab. The pharmacological intervention, short-acting benzodiazepines are okay, but watch the Xanax. When we're talking about older adults, just a little bit goes a long way. So typically you don't want to do anything over 2 milligrams of Xanax with your older adults. Your antipsychotics, you can use the Risperdal, but Haldol is usually the drug of choice when we talk about delirium. The best advice for dosing on any med for older adults. This is not just your Haldols and your Ativans and your benzos or anything. This is any drug for an older adult. You start low, meaning the lowest dose physically possible, and you slowly titrate them up. So these are the people that you can start them on like 20 milligrams of Lasix and then kind of slowly going up from there. Because if you just bump them with that 100 milligram dose, then all of a sudden these other things start happening. And nobody knows if it was something as simple as the Lasix, because we don't see too many side effects, that often from Lasix. But with the older adults, you never know. So you want to start low and go slow. Kind of like that guy from the One Call, that's all. There actually are no drugs currently FDA approved for the treatment of delirium. So practice guidelines, which are really just based on case series and anecdotal reports, says to use Haldol. Remember, it's a dopamine receptor antagonist. So it's going to inhibit the dopamine neurotransmitters that result in a sedative effect with improvement in symptoms. But that's it. So you're essentially treating symptoms here. You're not treating the cause whatsoever, all right? So like putting that Band-Aid on that, gushing carotid artery that got sliced. It'll help with the hallucinations and agitations and combative behavior, but if they're the hypoactive delirium, it's not going to do you any good. Other candidate antipsychotics or neuroleptic agents usually help the hyper and the hypoactive delirium, but you will not often see that used here. A lot of times we tend to see like the Risperidals and some of these other medications used for other reasons, unfortunately. You got to watch for adverse side effects, so EKGs. That QT, right? It's a little bit ticky whenever something happens in the body. Any kind of arrhythmias, and what are extrapyramidal? I cannot say that word. I never have been able to say it. I say EPS. What is that?
That's like the facial twitching.
Right. What else? What is it? What kind of a disease process does it look a lot like?
Parkinson's.
Right, Parkinson's. So once you think about a Parkinson's person, that's exactly what the EPS are like. So akinesia or akathisia. That's your $20 words, right, Carol? Either you can't initiate the movement, like they freeze, or they can't remain motionless and they have the tics and the jerks and that kind of a thing. Okay? So we're going to move on to DTs and go through this real quick. The background is another medical emergency, so anytime you see the word delirium, you know you got an emergency. Again, same thing, high mortality rate. You got to detect it, and it's usually the sympathetic overdrive that actually is leading to the cardiovascular collapse. So you think about the parasympathetic and the sympathetic nervous systems, and you can just follow it down the line. It's usually 3 to 10 days after the last alcoholic beverage consumption. And, oops, sorry about that. Obviously, if they have a history of alcohol withdrawal seizures, sort of like they once had a DVT, they're going to have another DVT. If they have ever had DTs in the past, they could definitely have it in the future. And if they're prolonged daily alcohol consumption, we're actually seeing a lot of research studies. It doesn't have to be that prolonged. It can be over the course of, a couple of weeks versus a couple of months. It doesn't have to be a couple of years necessarily. If they have a concurrent illness, that really ups the ante. Any prior withdrawals, intense cravings, and they usually present severe symptoms. So when the alcohol is withdrawn, they have a functional decrease in the inhibitory neurotransmitter GABA, and not the yo-yo GABA. I have a toddler, so every time I think of that, I get the little image of the little yo GABA people in my head. But that can make you crazy thinking of that cartoon for toddlers, so it makes me think that it just makes the brain crazy going on. You got a loss of inhibitory control and excitatory neurotransmitters, and that's listed below, those 3 neurotransmitters. And so it causes the symptoms of the actual withdrawal. So what happens? Tremors, agitation, hallucinations. The seizures can be grand mal seizures. These can be absolutely medical emergencies. Unfortunately, a friend of ours' brother died because he seized at home and did not stop the seizures from his alcohol withdrawal. And he had been through Alcoholics Anonymous and everything, so it was a pretty sad story. The complications is oversedation, respiratory depression, failure, and of course, arrest. Aspiration pneumonia, that's what possibly could have happened with this friend of the family's brother. God bless you. Cardiac arrhythmias, God bless you. 3 for luck. And remember, on the cardiac arrhythmias, you're going to be watching for that QT prolongation. Your mortality rate is anywhere from 5 to 15%. That's pretty high with something as common as DTs. But usually you're going to see the reason for the death is because of respiratory failure or cardiac arrhythmias. So other possible complications, obviously injury like falls or to other cells because they go into delirium. They can have those irregular heartbeats that could go into a life-threatening arrhythmia, and then seizures. So what do you do to find out about DTs and alcohol withdrawal? Obviously the routine labs that we all see listed there, but don't forget about the creatinine phosphokinase, because some patients actually can develop rhabdomyolysis on this one, and it's something that we tend to overlook. We're used to looking at liver function tests because we assume the liver is going to be the worst one. But remember, who's the other person working with the liver is the kidney, so you got to watch the BUN and creatinine, and then of course all your other electrolytes are involved as well. You're thinking about lipase, you just back up to what is the liver actually doing when it comes to metabolism of different things in the body. And then ketones, so you're also thinking about what can happen with the ketosis issue. The chest x-ray, you're looking for those concurrent infections, so pneumonia tends to be one of the really common ones. If they actually had trauma, you're going to do a C-spine. CT scans for any new onset seizures, more than 6 seizures, and you can see the others listed there. And obviously a tox screen, but are we ever going to expect that to be even remotely within normals? No, exactly. So, what's the new to ETOH protocol? What do we know about the seawall? That they have to be able to talk to you to answer the questions, so don't even think about doing a seawall unless they can talk. And then some of the medications we'll go over, anticonvulsants, sedatives, and CNSs. Alright, so here it is. This is basically copied and pasted without the person's signature on the bottom. So remember that all the ones up here, you actually have to say, indicate desired route of administration. So is it PO, IV, IM, suppository, whatever. That actually has to be filled to the far left. And then they're going to select one of these options. You can do the Cirex route, the Ativan route, the Haldol route, or substitute Ativan for Cirex until vomiting resolved, and then you go back to the Cirex. So it pretty much gives the nurse, for the patient, the ability to pretty much do what you have to do and not constantly be calling the physician every 5 minutes saying, oh my gosh, the patient's doing this, now what will you do? But realize the assessment monitoring is a key piece. You have to monitor the Ciwa scale every 4 hours until the Ciwa scale remains less than 10 for an entire 24-hour period. So you can't say, oh, I got a 10, we're going to 3 med surge, and then we're all done. You know, because 3 med surge, you hope they have time to be doing the Ciwa every 4 hours. But honestly, for that patient to be truly okay and like off of the Ciwa, you've really got to get a whole 24 hours of them being less than 10. So then here's your tapering dosages, and notify at the bottom. You've got to discontinue and contact the physician if the clinical symptoms persist. Clinical symptoms persist. There we go. So notify the physician of escalating withdrawal symptoms despite the appropriate medication administration. And y'all have had these people. You know, you give 1 dose of Ativan, nothing happens. 2 doses of Ativan, nothing happens. And you're thinking, my God, please, 3rd time's the charm. And then they're snowed. And then you back off. And then they're climbing the bed rails. And they're pulling out everything. And they're screaming explicatives. And then you nail them again with the drugs, right? So a lot of times with the older adults, you shouldn't think like that. What's the key little saying? Not one call, that's all, but start low and go slow. Exactly, very good. So you want to start at those low doses and then realize you've always got more that you can give. But if you start at the highest dose to try and knock somebody out, dang it, you don't know when everything's actually going to kick in, and then you don't know when it's going to wear off. Okay? So just be aware of that. And every patient that comes in reacts differently, so it's always a fun game. So, this is the Ciwa AR, which is the Addiction Research Foundation Clinical Institute Withdrawal Assessment. Alcohol, you can actually say that. So, you're actually going to assess all these different areas. You get a score of 0 to 7, except for orientation. That's only a 0 for 4. And if you get a score of 10 or more, you actually need to call the physician. So, if a patient can't talk, you can't use the Ciwa protocol, because what are you going to write for the answers for all those questions you got to ask them, right? You got no answers, you got no Ciwa score, okay? They may actually be in delirium, and the Ciwa treatment, meaning the benzodiazepines, will make the delirium worse, okay? So just be aware of that. And don't allow inappropriate use of the Ciwa. A lot of times we think, well, let's use the Ciwa protocol because it's got Haldol and Ativan, and that's really what I think I need to give. Well, if they can't talk, then when somebody does a chart audit, somebody's going to get hung out to dry for the inappropriate use of the Ciwa protocol, because is that patient going to get discharged on the right day? No, they're in delirium. They're going to have a longer length of stay. They're probably going to have complications, and they may even have other additional injuries that have happened because of it. So we really need to have judicious use of that Ciwa protocol. Okay, so 0 to 9, what do the scores mean? Pretty much absent or minimal withdrawal. You got a 10 to 19, that's kind of like mild to moderate. You got over 20, and you're looking at severe withdrawal for that patient. And remember, everybody presents a little differently. So a 20 for one patient may look a lot different than a 20 for another patient. So when do they need to be in the ICU? If they got a score of 35 or greater, oh yeah. If they need every 1 hour assessment for longer than 8 hours. If they needed 1 hour assessment for less than 8 hours, you could probably handle them someplace outside of the ICU. It wouldn't be real safe, but you might be able to handle them outside the ICU. But if it's longer than 8 hours, forget it. You need like a one-on-one there. How about 4 milligrams per hour of lorazepam, or 20 milligrams per hour of diazepam for more than 3 hours, or 3 hours or more? And then, of course, any kind of respiratory distress. That's pretty easy. The threshold between 8 and 10 is selected, and no more meds are going to be needed if this patient's less than the threshold. So that's really what you're kind of looking for. Once you exceed it, you can do the graduated doses. You can use additional PRNs. So remember, you've got that actually already on your Ciwa protocol for you. If you read the protocol real well, you don't necessarily have to be calling the physician quite a bit. So anybody working night shift, make sure you know that protocol back and forth. Remember, the vital signs are performed at regular intervals, because sometimes that can give you an early warning sign. And then the Ciwa scores are repeated regularly. Remember, every 4 hours until you get something nice and normal, below 10 for 24 hours. So the protocol discontinued once the patient has 3 determinators that are under the threshold, or again, your 24-hour thing. Oops, hang on. So I am going to cheat and skip forward and show you
Mr. Fenn,
Mr.
73
Fenn.
years old, has been admitted to the hospital with a broken hip.
Your surgery is scheduled for tomorrow in the morning, and our goal is to repair your hip as soon as possible, because this helps to decrease your pain level and also it improves the healing process. I want to ask you some questions because I want to assess your thinking ability, because on this floor, and especially with what you've experienced with your hip, that your fractured hip, we like to monitor a patient's thinking ability as often as we monitor a patient's blood pressure. So I'm going to ask you some quick questions. Okay?
Okay, they did in the emergency also.
Oh, they also asked these questions earlier. Well, can you spell the word world for me backwards, please?
World, backward, D, L, R, O, W.
Were any of y'all having a hard time doing
Perfect.
it? You might be in delirium.
How about, can you tell me what's today's date?
Today is Wednesday, September 12, 2007.
Perfect. And can you tell me how long or how many hours you've been in the hospital?
I think it's about 6 hours now.
And when is your birthday?
I will be 74 on November 2nd.
And that's all the questions I have for you right now. I do want to let you know, though, expect to be asked these questions frequently, okay? Because, like I said, it's very important that we monitor your thinking ability. Still assessing that you are in pain. I'm going to be right back, and I'm going to bring you your pain medicine.
Okay,
Do you need anything else while I'm back before I bring your pain medicine?
No, thank you. You have been very kind to me. Thank you.
All right, so that's basically his normal. Here we have a few hours later.
Hi, Mr. Fenn. Do you remember me? I'm your nurse. My name's Aria. Mr. Fenn, are you okay?
I think so.
Do you know where you are, Mr. Fenn?
I'm in my home. But it looks strange.
Mr. Fenn, actually, you're in the hospital right now. Do you remember why you're here?
Why?
You fell at home this morning and you broke your hip.
I did? Why I don't remember that? Am I going crazy?
No, my friend, don't get scared. It is very common for patients to get a little confused and sometimes for their brain to get a little fuzzy when they're new in the hospital. But you're okay. Mr. Fenn, can you please tell me the date today? What day is today, sir?
I think I'm thirsty. Can
Well,
I
you-
get some drink?
Yeah, you have some water right here. I'm going to help you to drink some. Mr.
Noticing
Fenn, the
attention.
water's right here, sir.
He doesn't even remember asking for the water.
Mr. Fenn, can you tell me what your birth date is, please? When were you born?
My birthday. I don't know.
I'm going to ask you a question that I asked you earlier. Can you please spell the word world backwards?
Word. What happened?
Well, nothing's wrong, Mr. Fenn. Don't be scared. Can you
Reassurance.
count from 20 down to 1?
Yes. 20, 19, 11,
Did he get it right?
15.
I mean, you could pretty much stop him right there. He doesn't even have to keep going. You know, he's failing it. So, what's happening with Mr. Fenn is that he came in with his broken hip and he hadn't even gone to surgery yet. But because his body's trying to compensate for what's going on and he's in a different environment, and it may even be that he's coming for a broken hip but nobody's realized yet. Maybe the UACNS hasn't come back and he's also actually got a UTI, because that happened because he got dehydrated, and that's why he actually fell and broke his hip, was because he was dehydrated from the UTI. So we got all this other stuff going on that might have actually, now he's in delirium, but he didn't present with delirium, okay? So that's why it's really helpful to get a background and a history on these patients, to kind of know what their baseline is, and then you have something to measure that against. Because that was just a few hours after he was admitted and he went into delirium. So realize it's not something that they always present with. It can happen actually during their hospital stay. Now he was sort of like a normal, he was like a little alert, he wasn't hyperactive or anything else, kind of a delirium patient. But I'm pretty, where is she? Pretty sure y'all know this lady.
Oh.
Whoops, hang on. Ignore that for a second. Skip around the patient.
Mrs. Bunn.
What?
Mrs. Bunn, let's leave your catheter alone.
Oh.
Okay. Oh, here, let's
Oh,
put
I
your
have to go to
oxygen
the
back
bank,
on.
dear. I've got to go.
Okay, let's
go
sit
get
down.
my checks
Put
in.
your oxygen back
I
on.
have to go. No. I have to
Thank you
go.
very much.
I mean, that's usually the patient you see, right? Now, if Mr. Fenn was just sitting politely, he's not doing all of this. He is usually the patient we miss. This one we catch pretty easy. It's the Mr. Fenns that we tend to miss in the hospital. Okay?
One of the major issues
And
when
they
we
talk
talk
quite a bit,
about
so we're getting out of that.
delirium.
Alrighty, so there's a couple of case studies listed here, but for time's sake, I know we got started late, but I wanted to try and get y'all back on track. You can read through those, but realize that essentially you want to know whether or not they're in delirium. But if you're suspecting because they have a history of alcohol, or maybe your toxicology screen's coming back positive for alcohol, if you know that they're in delirium, then you go ahead and you stick them on that Ciwa protocol. But remember, ask all of those questions for it, make sure that it's appropriate, and then we can take it from there. But never, with an older adult, think of one reason. They're always multifaceted. I call them the true critical cares, because they could be on 1 or 2, 3 med-surg, but whenever they come into the hospital, they always have like 3 or 4 different things that are going wrong with them. All right. So even if they're on a Ciwa protocol, be looking for UTIs, be looking for pneumonias, be looking for hypovolemias, be looking for metabolic and electrolyte imbalances. So be looking for a lot of other things, because it's typically multiple reasons that they're going to be in delirium. The delirium tremens, pretty much is going to be the alcohol. But always think outside the box when it comes to older adults. And then last but not least, I remember, some of y'all remember when I was pregnant? Well, there's what it looks like when it's out. That is actually my 2.5-year-old Luke, and that is my 7-month-old Julia. So that's the story of my life. And unfortunately, the HRSA grant is coming to an end. It was only a 3-year comprehensive geriatric education grant, so it's actually over in 2012. But we've had a fantastic time, like helping y'all out and mentoring y'all here at Piedmont Noonan Hospital. And I really do appreciate coming here, because I've worked at Maine Piedmont for a really long period of time. That's a 500-bed hospital with a whole lot of people. And if you've never worked in some of those huge hospitals and then come to a 140-something bed hospital where everybody else knows everybody else, it's like coming to Cheers. It's just such a breath of fresh air to come to Noonan Hospital. So whenever, you know, you're getting down in the dumps and when are we going to the new hospital and are we going to grow too big, just do like an agency shift at some of the larger hospitals and you realize how wonderful you have it here at Piedmont Noonan Hospital. So, thank y'all much.
Thank you, Mom.